There is a condition called as abruptio placentae or placental abruption. The premature detachment of the placenta from the wall of the uterus causing severe antepartum bleeding and potentially fetal death. Trauma, preeclampsia, and drug usage like cocaine are common risk factors for the condition placental abruption. Disseminated intravascular coagulation is frequently associated with placental abruption. The abnormal attachment of the placenta directly into the myometrium due to a defective decidual layer is called as placenta accreta. Prior caesarean section and endometrial inflammation typically predispose to condition placenta accreta. Massive hemorrhage is seen after delivery of a baby in a patients with placenta accreta. This is a picture showing placental accreta condition. Hysterectomy performed following massive postpartum hemorrhage, and the retained placental tissue prevents the uterus from contracting properly to occlude the bleeding vessels that results from the separation of the placenta. Now coming to the other condition, placenta previa. The abnormal attachment of the placenta to the lower part of the uterus partially or completely covering the cervical os is called as placenta previa, and it is usually presenting as painless bleeding in any trimester. Classification of spontaneous abortions. Threatened abortions, history is bleeding and viability of pregnancy is uncertain. Treatment is done ultrasound or following HCG levels. Inevitable abortion because of bleeding. Abortion is inevitable. Treatment is dilatation and curettage. Incomplete abortion, there will be cramping, bleeding with some passage of the tissues, and they are non-viable. So treatment is dilatation and curettage. Complete abortion, there will be history of cramping, history of bleeding and passage of all tissue. It is non-viable. Treatment is to follow HCG levels till they become negative. Missed abortion, there will be no symptoms in the history and pregnancy is non-viable. Then the treatment is dilatation and curettage. Hydatidifomb mole, it is a gestational trophoblastic disease GTD with proliferation of the placental tissue seen in teenage group and also in 40 to 50 years. Hydatidifomb mole is of two types. One is complete mole and the other condition is partial mole. Complete mole pathogenesis is fertilization of an empty egg by a sperm with a duplication of its genetic material, and this genetic material is completely of paternal origin. Complete mole paternal origin. Karyotype is diploid and the most common is 46XX. Embryo is not identified in complete mole. Complications include risk of development of invasive mole and also choriocarcinoma. Mole, the pathogenesis is it is because of the fertilization of an egg with two sperms. As a result, there will be triploid 69XXY, and here you can identify the embryo, the fetal tissues are present. Complications include risk of development of invasive mole, but a partial mole rarely complicated to choriocarcinoma. Complete mole diploid, partial mole triploid, and in complete mole all chromosomes are paternal, and in partial mole there will be two sets of paternal chromosomes, and there will be no embryonic or fetal tissue seen in complete mole, whereas it is seen in partial mole. Hydatiform mole gross examination. This is one more picture, and this is a microscopic of hydatiform mole showing hydropic villus core, and there is proliferation of the cells, cytotrophoblast and syncytio trophoblast. Morphology of hydatidiform mole is grossly they are cystically thin-walled, translucent, friable mass of grape-like structures. Typically, in a complete mole, all or most of the villi are enlarged and edematous, called as hydropic, and scalloped in shape with central cavitations or cisterns. Trophoblastic hyperplasia is well marked, covering the entire villus circumference. Partial mole, only a fraction of villi are enlarged and edematous, and the trophoblastic hyperplasia is focal and less marked. Clinical picture is spontaneous miscarriage. Investigations include elevated HCG levels and ultrasonography. Avascular villi with hydrophic degeneration, and there is trophoblastic proliferation, and the cells include cytotrophoblasts and syncytiotrophoblasts. Ovum, it is empty in complete mole, whereas it is partial mole normal. Androgens is seen in completely mole, not seen in partial mole. Karyotype is diploid in complete mole and it is triploid in partial mole. There will be villous edema seen in almost all the villi in complete mole. It is seen in few villi in partial mole. And the trophoblastic proliferation is circumferential in complete mole and it is focal in partial mole. The fetal tissues are not identified in complete mole, whereas they are seen in partial mole. And the serum HCG levels are elevated in both the condition, but it is more elevated in complete mole when compared to partial mole. The risk for choriocarcinoma is more with complete mole and it is rare with the partial mole. A 40 years old female presenting with 16 weeks of amenorrhea, and on examination her uterus, it was larger and corresponding to 21 weeks of gestational age. And she complains bleeding and passage of grape-like vesicles per vagina. Her blood and urine HCG levels are elevated and higher than normal pregnancy. What is your provisional diagnosis? And mention the two types of this benign non-invasive lesion and discuss their differential pathology, including the gross and microscopic picture, and also write briefly about the complications. 55 years old female had 12 weeks of amenorrhea. She is married for 1 year and on examination her uterus size was larger corresponding to 20 weeks of gestational age. She has complaints of passing grape-like vesicles and her blood and urine HCG levels are elevated more than the normal pregnancy levels. What is your provisional diagnosis? Describe gross and microscopic picture of the lesion and describe its complications. Plastic tumors. Gestational choriocarcinoma, placental site trophoblastic carcinoma, trophoblastic tumor, epithelioid trophoblastic tumor or ETT, and mixed trophoblastic tumor or gestational trophoblastic tumors. Choriocarcinoma, it is a malignant tumor consisting of trophoblastic cells with predisposing condition, complete mole, previous abortions, ectopic pregnancy or a normal pregnant woman. Grossly, a choriocarcinoma is soft, fleshy and yellow-white tumor with large areas of necrosis and extensive hemorrhage. Microscopically, choriocarcinoma shows proliferating cytotrophoblasts and syncytiotrophoblasts without villi formation. There is abundant mitosis with some atypical forms. Clinically, a choriocarcinoma shows the history of irregular vaginal spotting of bloody brown fluid, and the investigations include elevated HCG levels. This choriocarcinoma most commonly metastasizes to lung and also vagina. Among gross and microscopic picture, in the gross you can see dimorphic population of tumor cells and areas of hemorrhage. In the microscopy you can see dimorphic population of tumor cells and areas of hemorrhage. What is the difference between a male genital tract and a female genital tract? There is a vast difference. Thank you for your patient listening.